We're here at the CROI making a special presentation with Warren Dinges, who is with the Seattle Treatment Infectious Disease Clinic. And we're doing a presentation especially on antiretrovirals and understanding them from a patient perspective. I think it's really important, and as you do, that we have a sense of understanding of how the antivirals work, maybe a little bit about how to prevent getting HIV. And we're going to actually have a special other program on PrEP that you'll be able to give as well. So that's going to be to watch for. So I think refresh the screen on that, and then we'll go ahead and probably begin the program. We appreciate your coming here and taking this valuable time with us so that we can understand how antiretroviral treatments work. Thank you very much, Warren.
Okay, thank you. I'm happy to be here. So first, just wanted to say this talk is going to be about antiretroviral therapy and the specific medications we use to treat it. This is a diagram of the HIV life cycle, and if you notice, it starts with attachment of the virus to a CD4 T cell, and then it goes through a process of uncoding. Then the viral RNA has to be turned into DNA, and we call that reverse transcription. And then it basically gets duplicated into DNA with 2 strands. That goes to the nucleus, and then it actually integrates into the host cell. And then to make new viruses, you have to make messenger RNA. That messenger RNA has to be processed, and then viral proteins formed, a new virus formed, and then a progeny virus comes off the cell. And we have medications that act at about 4 of these steps currently. This is a diagram of exactly where those steps are, where we have medications. We have ones that prevent attachment of the virus to the cell in 1. We have reverse transcriptase inhibitors that prevent reverse transcription from RNA to DNA. We have integrase inhibitors at 3 that prevent integration of the viral DNA into the host cell. And then lastly, the final step is 6, where we have, in essence, maturation inhibitors, which protease inhibitors work at that stage or in the processing of viral proteins in the cell. And this is a list of all of the antiretrovirals that are approved for use in the USA. And one thing to notice immediately is all the medications have at least 3 names, which makes it somewhat confusing. Most of the physicians practicing use either the 3-letter digits or they use the ones on the right-hand side. While patients, when they pick up their medications at the pharmacy, they all know the ones on the far left, the trade names.
Right.
So all of my patients...
This is kind of a really bizarre situation because now you have to know them all because you have 2 different elements of your care attending to one or the other.
Right, and so when I sit down and try to take a medication history from a patient, we have the list of the names of the medicines. We also then have pictures of the pills, but the pill shapes have also changed through different formulations.
Right, this is another challenge. I think some of the companies like Kaiser, I think, does that. They'll change the look of the pill, and not necessarily just HIV drugs, but other drugs for other diseases. Yeah.
Right. And so, in general, when we look at designing antiretroviral therapy regimens, this developed in basically the late 80s and early 90s. We take 2 medications that are nucleosides, and we call those nukes. They're always paired together, and they match the A's, C's, T's, and G's that make up our DNA. And you always use, say, a thymidine analog and a guanosine analog. That's for the A and or the T and the G. And so we found that if you pair one of those with some other medication, that is what makes antiretroviral therapy. So we would take 2 of the nukes and either one of the non-nucleoside reverse transcriptase inhibitors, or 2 of the nukes and one of the protease inhibitors, or 2 of the nukes and one of the integrase inhibitors. And some other medications I mentioned block attachment of the virus are like infiravirtide and maraviroc, where also can be used in antiretroviral therapy. And then there's this one other class of medicines down at the bottom left that are really, we call them PK boosters. They raise the level of other drugs so that we make the other drugs, particularly protease inhibitors or L-Vitegravir, more effective so that we can take them once a day as a more convenient regimen.
And Norvir actually started out as an antiviral, but it's now,
yes,
it does have that property, but not that great. It's I would say, a bad drug, but
correct.
But
I mean,
it's small dose. It does what it needs to do.
And you have to use a lot more of it to be active as an antiretroviral in and of itself. It takes 8 pills at least per day, as opposed to when we're using it as a booster, we can use as few as 1 pill a day. All right, so if you notice, what happened then in the HIV treatment regimen is we started making combinations. Since we always use the nucleosides as pairs, there are several drugs, 3 listed over there, that are nucleoside combinations. Combivir, Epsicom, and Truvada. Trizavir is on there also as a 3 nucleoside combination, but we don't really use it much anymore. And then what we have since 2006, Atripla was the first single tablet regimen. It's 1 pill once daily that treats HIV. Since then, 3 others have come out: Complera, Stribild, and Triomec. And each of them, in essence, are just 1 pill taken daily that completely treats HIV. And most recently, there's been 2 new protease inhibitors approved even just last month, which are Evotaz and Prescovix, which have a boosting medicine in them so that their active protease inhibitor, atazanavir and darunavir, respectively, can be given once daily through a single pill. And then there's the older Kaletra, which has been around for quite some time and is still a very effective medication but has some side effects. The question is then, how do we choose amongst these regimens? And what you see here is I've narrowed that list of large number of HIV medicines to the ones that are currently recommended by the Department of Health and Human Services guidelines, and equivalent medications that very likely with the next guidelines will be included in them. And what you see at the top are the non-nucleoside reverse transcriptase inhibitor-based regimens, the two most common being Atripla and Complera. And there's also Sestiva, Epsicom. In the middle are these PI-based regimens we call protease inhibitors. These medications have a very high barrier to resistance. It takes many mutations in the virus for them to get through those medications. And the last one are the newest combination pills, which are called integrase inhibitor-based combinations. And in bold are all the medicines that are part of the single tablet daily regimens, or STRs. And you see here that Stribild and Triomec are one of the newest integrase inhibitor regimens. And actually those represent probably 80% of my new starts of people when they start medication now. They're very well tolerated with very few side effects.
Do you and/or your patients have a stronger predilection to selecting based upon the resistance data in their virus, or is it more or less the kind of drug and the single tablet or dual, that if they're really adherent, then maybe 2 times a day wouldn't be a challenge?
Right. There's a lot of different reasons the patient choose one regimen, and basically all of those are issues we discuss. And these are sort of some of the things that go into the selection process of the regimens. There's basically having this HLA-B5701 means that you can't take abacavir, which is included in those 4 medicines. Having a very high viral load means you want to avoid some medicines that have been weaker or not as strong. Complera is one of them, and the regimen with Sestiva and Epsicom is also similarly weak. One of the medications, tenofovir, that is in Stribild, Complera, Atripla, Truvada, and Viriad, is a problem for people who have impaired kidney function. So we want to see a kidney function measure, and if their kidney function is impaired, they can't take that medicine. And then also, as I mentioned, people who have poor adherence, we tend to use a protease inhibitor-based regimen because it seems to tolerate people missing more doses, as opposed to some of the non-nucleoside reverse transcriptase inhibitor regimens really need someone to be more than 90% adherent to not get drug resistance. While protease inhibitors down to 70–75% resistance, and people will still remain suppressed. There's also a question of cardiovascular disease risk with one of the medicines, abacavir. There's discussions in the field, and that's still open, and actually at this conference we should know some more from the NA Accord data on whether or not Triomec, Epsicom, Xiagen, and Trizavir should be avoided or not in people at high risk for heart disease. And lastly, as we discussed pill count, single tablet regimens are just much easier to take. They can do it 1 time a day. Some of the single tablet regimens, it's best to take it just at night. Some have to be with food, but others have no real association with food or what time of day, such as Stribild and Triomec. And lastly, there are drug interactions with cobicistat and ritonavir, those 2 PK boosters. And if someone's on a lot of regimens due to many health problems or a lot of medications due to health problems.
Co-diseases and so forth.
Exactly. We sometimes have to avoid ritonavir or cobicistat, so avoiding those boosted regimens.
You find a lot of issues around the adherence today. I mean, I've talked to a lot of, especially company people, about doing more programs on adherence because it's like you say, and some medications are less forgiving, and so it's more challenging and more important that people become more adherent. Do you feel like we should have more patient education on adherence or regular?
Yeah, I think that and some more unique ways of reminding patients. There's some computer programs that will send basically a text message to remind people to take their pills. And there's actually even a smartphone that has a pill box in the back. And if you haven't opened the pill box, it will basically nag at you until you open your pill box and take your pill daily. And some of those interventions may actually markedly increase adherence. I still, though, have some of my patients with no real help other than their own. They've never missed a dose of their antiretroviral therapy since they started it.
They're just really thoughtful. Yeah.
So one thing I wanted to just mention, sort of cost. We don't ever really discuss this much. But again, this is a slide of the recommended regimens. And this is the average wholesale price. In reality, pharmacies charge about 10 to 15% less than this. But you see the least expensive HIV regimen is $1,900, and the most expensive one is $2,950, the Stribild.
Well, you didn't put the T20 or Fusion on there.
I did not. It's expensive. I actually haven't written a prescription for Fusion in more than 8 years.
And we're not talking about hepatitis yet, so
right.
That's another huge expense. So.
But I mean, for a typical person, you're looking at $30,000 to $35,000 per year in medication expenses.
That's a lot, yeah.
There's a lot of money.
But it's worth it if we have people for two reasons. One is they're treating themselves, plus they're treating the ability to not infect others.
Correct. And they remain healthy on these regimens likely for the duration of their life and will die from other things, not from HIV. I've not had one of my HIV patients die from HIV-associated illness in more than a decade. So what's coming for future ARTs? There's a new tenofovir that's going to be coming out, and it doesn't have the kidney problems that the current tenofovir has. And when that happens, there's also a problem with bone mineral density with tenofovir as well as all other nucleosides. And I think we'll see a new Stribild and a new Complera that has this new TAF in it, we call it. Also, Truvada is going to be in that medication. The first single pill protease inhibitor regimen is going to be out soon. We call that DCF TAF, and it involves a darunavir boosted protease inhibitor regimen, and likely with emtricitabine and the new tenofovir that's coming out. And at this conference, we'll see the data likely for the cardiovascular disease risk from the NA Accord data. I think and that's going to provide a definitive answer on whether or not we really believe abacavir cardiovascular disease associations. There will be some more data on a new nucleoside reverse transcriptase inhibitor, and where this one will have particular utility, as I mentioned, the low barrier to resistance of these non-nukes. This one actually can tolerate the two most common drug resistance mutations that are in the NNRTI class. And lastly, I think something we're going to see more over the next 3 to 4 years is formulary restrictions. When we have so many singlet tablet regimens that are basically equivalent and have basically no side effects, there's going to be some competition between drug companies as well as then the pharmacies making contracts, as we've seen in the hepatitis field. And I also think that as more and more of the antiretrovirals go off trade drug status and become generics, we might actually see greater price pressure downward on antiretroviral therapy. So that is going to come in the next 3 to 5 years also. And I think also one issue that I'm seeing with some of my patients are those who have basically gotten on an Affordable Care Act plan is they're having enormous deductibles in their first few months of the year. So a patient is being asked to put $5,000 to $6,000 of a deductible before their insurance will start covering their medication cost. And this is a strong problem early in the year when they're in essence in a donut hole that we saw with Part D Medicare plans when those were implemented. We're seeing the same donut hole now in ACA plans.
And we just can't have interruption of treatment for people who are, first of all, wanting it, and secondly, need it very badly to make sure that not only they're protecting themselves, but others.
Yes, absolutely. I had one of my patients who he switched healthcare plans this past, or his partner did in November, and went off treatment. And then his partner infected him, and he came to see me in primary HIV infection from an infection in December solely for a lapse in his coverage. So,
this is a story that needs to be told, and especially to the people who can make a difference and make some changes in the policy.
yes. So basically what we know about antiretroviral therapy is that it's well tolerated, it's extremely effective, and that it's expensive. And we're moving to more single tablet regimens, specifically Stribild, Triumec, and to a lesser extent Complera, and to a more lesser extent AAA. And that we're eventually going to have these two other medicines that are in essence Stribild and Complera with the new TAF medication in it. We'll also see soon this DCF-TAF, which is the first protease inhibitor-based regimen. We will find probably the good answer on whether or not NA Accord data shows that abacavir is associated with cardiovascular disease risk. And I do think that we're going to see some formulary restrictions, and it's going to end up requiring quite a bit of work in the back offices of physician practices getting drugs approved. And hopefully we'll see some generic competition on price, reducing overall cost. When I put the slide together for the cost of these HIV medicines, I had done a similar talk about 5 years ago, and I noticed that all the costs had about doubled.
Yes.
And
so they don't double, they don't increase just once a year in some cases.
Correct.
They have multiple increases a year, which I don't get it. It's just unnecessary, I think, at this point.
And for some of the high deductible cost share issues, we have seen fairly robust copay assistance programs by companies. I've seen several companies pay up to $4,000 to $5,000 a year in copay assistance. And that's becoming very important in patients on ACA plans where they end up with a very high deductible cost at the start of the year. So that's it. Do you have any questions?
Yeah, I think there's a couple things. One is I'm really interested in the cardiovascular risks associated with HIV, and then of course you have it associated with association presumably with treatment, and it seems to be it's growing, and I know that there is huge risks comparatively speaking as far as smoking. I mean, it seems as though there's this profound, that there may not be nearly that smoking is really the more profound risk than the HIV or the drugs.
And what we've seen also is that in patients with HIV who do smoke, their rates of lung cancer associated with that smoking is up to 4-fold higher than people who don't have HIV. So, and that's true of several other cancers also, that in essence have a HIV-associated increased risk of cancer in a cancer you wouldn't normally expect to be associated with HIV infection.
So it's not really additive, it's greater than just additive.
Definitely. And that's why every single visit with all of my patients who smoke, I ask them how many of their cigarettes they're smoking and try to encourage them to stop.
So do you have a profile that you create for every patient? I mean, a lot of doctors do that. So you can get to know your patient better, and you have this sense of knowing them on paper as far as a criteria by the way they smoke, or they drink, or they, there's other issues, some of the social issues.
Yeah, definitely. I mean, I think now with the incentives for having electronic health record, almost all practices are going to electronic health records. My EHR has all of those components built into it. It has built into it smoking, it has built into it social history, it has a problem list, and all EHRs have that, the problem list. They have the medications that you update at every single visit. That's part of being a good physician in our current healthcare system. And I think it's critical when we're interacting with our patients, and not just what medications, but also what over-the-counter supplements they're taking. Are they physically active? Are they participating in health programs that are meant to improve health, such regular exercise programs like the Fitbit, people wearing watches to count steps per day. All of those are ways that patients are taking control of their health and ensuring their good health overall.
Do you have a sense of more, the activity is really good. Do you also balance what people eat into the equation, and dietary restrictions?
Definitely. I mean, the single most important thing is total body mass index. And we're actually have seen some recent adjustments in some of our information that we're getting from nutrition experts on diet. And we had previously had a strong focus on low sodium, low fat, and now we're switching more to total caloric intake, what is body mass index, avoiding bad fats like trans fats, but then also looking to how do you make a balanced diet and avoiding sort of empty calories of a lot of carbohydrates that are particularly processed carbohydrates like sugar, and go in more to whole grains and carbohydrates.
How often do you believe that people who are not infected should be tested for HIV? Is it based upon your because you do treat patients who are not infected but who may be in a high risk category?
Right, definitely. It depends on your risk factors. According to the basically CDC guidelines and the STD treatment guidelines, every sexually active person should be tested for HIV annually. And I increase that based on people who are more sexually active than that or have other risk factors. If people are in discordant relationships where their sex partner is HIV infected, it's important they get tested more often. And it's also in those same higher risk patients, we look to putting them on PrEP, which is actually what the later talk will be about. That's another very effective way of preventing HIV transmission and keeping my patients healthy.
Do you understand, or do you talk to your patients about treatment as prevention?
I do, and that's one of the strong issues, is that people with high viral loads particularly are at much higher risk of transmitting the virus. And there's a question of whether most of that transmission occurs right when people are newly infected versus whether that transmission occurs in chronic infection.
So, okay. Is there anything else you want to make sure you cover before we close? Because I know this is really an important topic for people, and antivirals are an important part of the, I mean, when you look at the antivirals we have today, and what 15 years ago was just a few.
Right.
It's profoundly amazing.
Virtually all of these regimens are once daily regimens, and they're 1, 2, or at most 3 pills a day. And if you saw the regimens that existed in the mid-90s, they had to be taken with food, without food, up to 15, 16 pills a day.
Side effects.
Enormous side effects, diarrhea. It was just, they were not tolerable regimens. There were Alka-Seltzer-like tablets that had to be put into water, and that's just
some that tasted like gasoline that you suggest that maybe chocolate would help, or applesauce or something, and it only made the applesauce taste terrible.
Right. It's very different, and I think some of the younger people who never saw that.
They don't have a clue.
20-year-olds who come in, they just have never seen that part.
Well, but on the other score, you have now a disease which has become less threatening, less concerning, but still, I had one doctor say to me, he says, I think this is probably still the worst day of a guy's life when they have to find out they're positive, because they're now on the other side of that fence, proverbial fence. I don't see it that way personally. I think it's a part of life, but and it's unfortunate, but it's certainly worthy of trying to avoid becoming positive, but understand how that can happen, truly understand how prevention can work. And I think that's one of the things we're going to be talking about in the other program, and I look forward to that program too.
And I think it's very important that you target the interventions to the people at highest risk, and the risk is defined by specific behaviors. I think the concept that everybody is at risk for HIV had us miss some of the issues, which is there are specific behaviors that put people at particularly higher risk and other behaviors that are much lower risk.
So modify your risk and understand the risk.
Correct.
And that will cover in the next program. Thank you very much. I appreciate your time.
Thank you.